Hello, welcome to Convergent Dialogues. This is Xavier Bonilla. On this episode, I'm speaking with Catherine Gordon. Katie is a licensed clinical psychologist. She is an associate professor of psychology at North Dakota State University and wears two hats. One hat she wears, she's still doing active research with self-injurious behaviors, with eating disorders. And in her other hat that she wears, she's a clinician and therapist and does therapy weekly. She is the author of a new book called The Suicidal Thoughts Workbook, CBT Skills to Reduce Emotional Pain, Increase Hope, and Prevent Suicide. And that's what we talk about in this episode. We talk about suicide. It's a really tough subject. And so I want to give a content warning. I don't typically do this for the podcast, but suicide is a really tough subject. And so, I wanted to be able to just kind of warn people ahead of time that, sometimes talking about suicide, people have, friends or family or loved ones that have committed that act, and it's very difficult for people to even listen to it or talk about it. And so if you have any challenges with talking or hearing about suicide, now is the chance to hit the pause button, and maybe this episode isn't for you. For everybody else, we tackle this really important subject. We keep it pretty much clinical, very, very clinical, and how we want to try and prevent this from happening, how clinicians can do that, and even how friends and family members can spot and notice suicide warning signs. We start the conversation by talking about her reasoning for writing the workbook and for studying suicide in general. We talk about the current data and statistics on suicide in the United States. We talk about the connection of suicide and mental illness. We discuss how to spot warning signs as these kind of precursors for suicidal gestures. We talk about ways to ask if someone is suicidal. Many times this is a very tough thing to do, and even clinicians can sometimes become quite nervous to ask if someone is suicidal. It's a very, very hard thing to ask. And so we spend some time talking about that. We talk about the differences between passive and active suicidal ideation. We talk about the safety contract versus a safety plan, the efficacy of those and what the differences are. We talk about self-injurious behaviors and their various differences from suicidal gestures. We talk about the dangers of discussing, suicide or suicidal content on social media. And we talk about the best ways to use her suicide workbook and how to prevent suicide. We end the conversation a little bit on a lighter note. We talk about some of her work with eating disorders and some of her research that she continues to do. And then we kind of engage each other about our love for Star Wars. She has a podcast that talks about some of the themes in psychology at present. And historically, I think she had a previous podcast about looking at psychological themes and, kind of popular films and stuff. And so we both have a love for Star Wars. So we kind of end on that note. And, I'll just say that this is, again, as I said in the beginning here, suicide is a really, really tough subject. I would say most people have had some interaction with it, again, whether it's family, friends, coworkers. And it's something that is still, kind of impacting and in some ways reshaping people's lives. I've had plenty of clients where this has, impacted them, and coworkers and even in my own personal life. And so suicide is a tough thing, but I think we need to definitely have conversations about it. I'll just say, anybody that is listening to this at this point, if you or a loved one is in a really dark place and they have some suicidal ideations, the National Suicide Prevention hotline is available. You can find it on Google. The number is 800-273-8255. It can be very helpful in preventing suicide. And so if you don't know that number, there it is. It's also first hit on Google. So definitely don't feel afraid to reach out. That can be really, really important. So I was super grateful and honored that Katie came on and talked about a tough subject with me. And I feel this conversation is super important, and I hope it's helpful for listeners out there. And so now I bring you Katie Gordon. I am here with Katie Gordon. Katie, what's going on?
Hi, Xavier. It's nice to talk to you today.
Yeah, no, it's fantastic to talk to you. I've been wanting to talk to you. I've been following you a little bit online and seeing your work, and so I'm looking forward to this. So I know it's a tough subject and something that affects everybody in our world, in the clinical world. It's something we have to deal with. So it's tough, but I really applaud you for doing the research and doing kind of the workbook on the clinical side and just really approaching this issue.
Thank you. I appreciate that.
So let's just briefly, just give me your brief, who you are, what your research is in, what you do, and what the book you just put out, and all the relevant stuff.
Sure. Sounds good. My name is Katie Gordon, and I have a PhD in clinical psychology from Florida State University, where I got to work with Thomas Joyner, who was a huge influence on my interest in suicide prevention. And then I was a professor at North Dakota State University for 10 years. And then a little over 2 years ago, I left academia to become a full-time therapist. And I continue to do some research in that role on eating disorders and suicidal behavior. And then recently on July 1st, my book, The Suicidal Thoughts Workbook, came out, which has a focus on CBT skills, but it's kind of broader than that too.
Mm-hmm. Mm-hmm. Yeah, no, it's great. I'll just say I had told you this before, but so I mean, I also do therapy. That's my day job, and I'm not a big workbook person. I'm not a big CBT person. It's not that I don't like CBT. I do actually, but my world is more kind of a contemporary psychodynamic approach. So it just clicks and makes sense for me. But I like CBT. I was trained in it and stuff. So so when I saw it, I my first thought was, oh, well, this is interesting. I wonder what this is like. And so then I got it, and it's quite good. It is quite good. I think it's something that in the book, and we'll talk about it, but in the workbook, I think you say in the beginning that the idea is that you kind of work through it start to finish in one way. But I think you could probably use things out of sequence as well. Is that true, or?
Absolutely. I think that often, and you know this as a clinician too, in therapy, you kind of are guided by what the patient needs and where they want to be. So the suggestion is to go from beginning to end to kind of pick up the different areas at least. But the truth is that I tried to make the second table of contents is very specific with the idea that people could jump to something that they need in that moment, whether it's to decrease emotional pain or increase connections or whatever it might be.
Mm-hmm. Yeah. So I definitely want to talk about the workbook. But before we do that, I wanted to just ask, doing research on suicide, I think it comes out of work with eating disorders and then kind of independent of that. Yeah. But why the interest in such a tough topic? I mean, anything in mental health is going to be tough, but I mean, suicide is really tough. I mean, that is just a really tough thing to talk about. It's tough to research. It's everyone's kind of affected by it. Usually at some point they know a friend, a coworker, a family member. And it's it's really tough. And so why the interest in this work?
I think there are a couple different sources of interest. One of the main ones is that I was interested in studying depression at first when I was an undergraduate, and then I was a research assistant in Thomas Joyner's lab and recognized that there was a huge need for more suicide research and why that was so important. So there's kind of that research aspect and the clinical need for it. And then when I was in high school, there were actually a couple of people who died by suicide that really impacted me. There was someone who, two of them went to my school, and that really affected me. And I thought about how much pain they were in and what could have helped them, and how much their families suffered when they were left behind. And so I think that part of it is kind of driven by this need in science to go to this area that is understudied. And then the other part of it is just very much wanting to help people who are in pain and try to understand it better. And since being in therapy, I think that's, or being a therapist, I should say, I think that that's built an even stronger desire to help people with suicidal thoughts, because I think it continues to be an area where people feel a lot of shame when they have suicidal thoughts. And so wanting to provide more tools for them to have accessible to them, and that kind of teaches them to relate to themselves in kinder ways, that really drives me to try to do my work and push forward some of the suicide prevention work.
Yeah, no, it's interesting, talking about your, people that you know in high school.
Mm-hmm.
It is one of those things that it regardless of, I mean, both you and I are clinicians, and so, but we're still, even though we're well trained and well equipped, we're still human, and it still, still hurts. It's still hard. A couple years ago, I think about 4 years ago now, 3 or 4 years ago now, I had a really good friend who pretty terribly, in a terrible way, took his own life. And it was a kind of a shock. It was a surprise. There was no real history of mental illness, at least not formally diagnosed. And it's tough. It was really, really tough. It was really, really hard. Yeah. And to this day, I still think about him probably once a week. And it's hard, especially, I mean, this person was very young. He was in his mid-30s. And, it's something that there's always this, loss that's there, right? There's always a hole that doesn't quite get filled, and it just kind of stays there. Loss of any sorts, but loss by suicide is a different type of loss. At least I would say probably, clinically, it's different than if, the grandma that's 95 and has, been on, hospice care or something like that. Or all loss is difficult, obviously, and it's very painful, but suicide is, when it's kind of shocking in that way, it's very difficult. And so, yes, so I went to therapy myself for that, and I even as a clinician, and I think it's important for clinicians to do that as well when they have really tough life adjustments and things of that nature. So it is something that impacts and affects every single person. And so while it is a very painful and a very difficult thing to research and study, we have to be more preventative, to be more proactive, to catch things early, to try and at least give people as much, resources and access to resources to try and prevent that. And that's why the workbook you have, I think, is very useful, is because, it's something else that is out there for people, and it's easily accessible. And so I think that's super important.
Thank you. And I am so sorry for your loss. I think that's so true, that most of us at some point or another are affected by suicide loss, and it's painful whether you're a clinician or not. We're people, and sometimes it can hurt even more because we can feel like we should have been able to sense or detect something, but that's not. It's humbling our limits and what we can do.
Oh yeah, absolutely. I mean, yeah, it is. I would agree. It's sometimes probably a little bit more difficult for us as clinicians because we just have we have a different perspective and understanding. Kind of the things that the precursors to when people do that, and so it's tough. It is sometimes a very hard thing to notice, and many suicide attempts and those that are completed or not are sort of on impulse sometimes. And so even if it's planned out, people in that moment, if someone were to get to them, talk to them, it could, they could change their mind or, and so, but not always, but it just depends. So yeah, so it is a little challenging even for clinicians because I think sometimes, I know I did, we always take it a little bit harder because we're supposed to see that stuff and catch it and all that. But okay, so let's start with, I don't want to make this too laborious, but I think it's really important, especially currently, on what are the current data and some of the statistics about suicide and what it looks like kind of, more recent past 30, 20, 30 years, and then what it is now in the past 5 to 10 years. And yeah, let's start with that and we can talk about some of the conceptual stuff. So what is the current data that we have on suicide?
Well, as of 2018, it was about 14.8 out of every 100,000 people died by suicide, and there was a trend for years of the suicide rate climbing. And then in 2019 and the preliminary data for 2020 suggest that started to turn around, that there was some decline in suicide deaths over the past 2 years. But before then, it was steadily climbing.
So the 14.8, you said, out of 100,000 is suicide deaths. That does not include attempts or any other thing of that. So unsuccessful, I guess you could say, attempts. It's those that are successful attempts that die by suicide.
Yeah, so that's 14.8 out of every 100,000 are deaths by suicide, and then researchers think that there are about 20 to 30 suicide attempts. This is an estimate per every death by suicide. And then when we get into the thoughts, people thinking about suicide, that's even higher. And so you can kind of see it affects a lot of people, whether we're looking at death attempts or suicidal thoughts.
The numbers that when I last looked at this and researched this was that between, I think, the early 90s until early 2000s, the suicide rates, let me see if I get this right, it was 65 plus was where it was the highest. And then sort of around mid 2000s, the range was 25 to 64. Is that right? 65, somewhere around there. And that was like the frame. So it was, literally from young adulthood until just before kind of, geriatric. And then, it began to climb. Is that kind of the pattern? So as the rates were rising, did the age gap also become wider, or is it very concentrated by age as much as you know?
That's a good question. It did seem like there was a shift from older adults, like say 85 plus, to more middle-aged adults in more recent years, where you see that. And it's not clear exactly why that is. Some people have thought about stressors that can occur during midlife, relationship issues, employment issues, and things like that may have contributed to it. But that did seem like a shift that happened.
Yeah, and on the gender side of things, and some of this is important, I think. Let me get this right. Males are more they complete suicide more often than females. I don't know if it's a 3-to-1. I can't recall. And females attempt more but complete less. Is that still current?
Yes, that's true in most places in the world, although not every country, but you do see a similar pattern where men are more likely to die by suicide and women are more likely to attempt suicide.
Mm-hmm. Now, the running hypothesis for this, and you can tell me what you think about this personally or what have you, is that men are typically, for various reasons, because of hormones, testosterone, etc., but they usually are more aggressive. And so their means of attempting suicide is usually more aggressive, handguns, shotguns, etc. Women, usually it's pills or other means that are less likely to die by that method. Is this still true as well? Or what are your thoughts on that?
Yeah, there does seem to be a link with methods and fatality. Most people who attempt suicide by firearm are likely to die as a result, whereas with overdoses, there are opportunities for intervention. And so there are some different lines of thought. One of the theories that's kind of informed my thinking about it is the interpersonal theory of suicide, which was created by my former graduate mentor, Thomas Joyner, and expanded on by my friend and colleague, Kim Van Orden, and other people in that area. And one of the aspects of the theory talks about capability for suicide and focuses on people who have lower fear of death and who are have a higher tolerance for pain. And sometimes that would mean that you'd suspect people who, for example, were in the military and had exposure to a lot of different, maybe have seen death or other types of painful things, that also apply to people who are medical doctors, maybe working in the emergency room. They are exposed to a lot of things that might actually habituate them to some of the fear and pain related to death, and that might actually increase their capability for suicide, such that if they desire, they could try a more lethal method. And that might have something to speak to the gender differences that tend to be observed in terms of life experiences and things like that.
Yeah, this is very interesting. This interpersonal kind of component to it, and what are kind of the antecedents for some of these things. Just the last thing on the numbers piece, if I recall, the taken together, males and females, the age range for suicide is 45 to 54, 55, if I recall. And then for females, when you just do it separately, it's the same. But males, it then is 75 plus. Is that true, right? In terms on the gender side?
That sounds right, but I trust you. I don't have the numbers right in front of me, so I don't want to say for sure. So I trust your memory on that. I'd have to look it up to double check.
I remember
my
having
own memory.
Memorize all this for a long time ago. But the idea though is that, so the central point here is that there seems to be something with middle age, right? Is you're talking 45 isn't old, right? It's in many ways, people can say that, late mid 30s to early to mid 40s, is where people can really thrive. They've got some, some they've learned a trade, or they've, finished college and, or, graduate school. They've worked in society. They have maybe retirement or savings. They've had a couple kids or not, but they're established. Maybe they have a house, maybe they have a car. This period of life is not a, early 20s, just out of mom and dad's house kind of thing, right? And, it's not 85 and you're at death's door. It's such a strange age, just on the face of it, to be like seeing numbers of people, male and female, saying, this is a time I'm going to just check out and just make my exit. I mean, what is there any conceptually or theoretically or empirically any ideas to indicate why this age, mid to mid 40s to mid 50s, what is it about that time period that we can understand of why this is maybe a sensitive or critical period?
Yeah, it's a good question. I think, unfortunately, within the suicide research field, there are some things that have been established, but there are a lot of things that when they change, like the age range or something like that, there are kind of informed speculations that people can make. And I think some of the big ones that I've seen with that is that can be an age where there's divorce, which can be something that is a major interpersonal disruption and stressor. Sure. It can be a time where people struggle with substance use, and that can be a risk factor for suicide as well. If someone is struggling with unemployment around that age range, it might be more stressful because they have kids or they have this kind of established life, or they might, part of Joiner's interpersonal theory of suicide is that people desire suicide when they feel like a burden. And if you're someone who is middle-aged and has a family and you're struggling with employment or you're struggling in some other kind of way, it might hit you differently. It might feel like more of a strain than at other points in your life where maybe if you're a young adult, you maybe have some kind of buffer against those types of feelings. So I think that those types of struggles might be linked to that, why we see that vulnerable period in middle age currently.
Yeah. I also think that sometimes for some people in that age range, that's where their own parents die. And if there's, or people, grandparents or some people they're super close to, and they can, if they don't have a big family or they're not married or whatever, that it can be more like, well, what's the point? Is this, this kind of hopelessness kind of sets in, which goes to the other point of, so if you're married, it's typically your chances of attempt or completing suicide are reduced. But if you're divorced, if you're separated, if you're widowed, those chances, and then single, I think that's the order, then your chances increase. Is that still kind of current?
Yeah, absolutely. Having meaningful connected relationships, which can come from all kinds of sources, are important. And I think that marriage is one of the places where you can look at, especially people in healthy marriages, where there can be a lot of benefits from that and a lot of connectedness coming from that.
Yeah. So just wrapping up a little bit on kind of the data, because I think it's important. The suicide data says highest for whites. Is that still true?
Yes, there's a little bit of, I guess, controversy around exactly how the numbers fall, because by nature of suicide being, it's not rare enough, right? It affects a lot of people, but relatively rare. Some groups where there are smaller numbers of people. So for example, in American Indian groups, there are smaller numbers. And so it's harder to get precise rates, but most estimates currently put white men in the United States at highest risk for death by suicide, but American Indian, Native American men also are at elevated risk for suicide.
Yeah, I was going to mention that point too. I think it's younger Native Americans or Inuit Alaska natives as well, that they have very, very high rates, relative to the numbers than the national average. But the risk factors here for suicide are, divorced, widowed, or single white men in their 40s and 50s. Those are all the risk factors, I guess you could say. Which is, I mean, again, right, what you just said, right? I mean, it obviously, unfortunately, affects more people. Obviously, it affects everyone. I don't like to spend too much time on the, gender or age or race kinds of things. I mean, this is the data that we have at the moment. And so anybody doing this at any age or any race or gender is something we want to prevent. But it is important to know what some of the current data is on suicide. Now, it's 60%, right, of folks that I think attempt suicide or complete suicide have a mood disorder. This is right. Is this still accurate?
I think that some of the more, so for example, I think this is really hard to study because there aren't as many people who have contact with the mental health care or medical care system and before they die by suicide. So I think this is hard to tell. Mood disorders are certainly one of the conditions that are related to elevated suicide risk. A more recent CDC study was reporting that 54% of people in the United States who died by suicide had no known mental illness. That doesn't mean that they weren't struggling in some way. Sure, and kind of looked at some of the stressors. But yes, those I'm not trying to be overly picky. I'm just
no. I think it's important to be accurate. That's important. Yeah. I have my data isn't completely current. I know some of this stuff doesn't change, so that's why I have you here. Keep me current. Yeah, but I think that's definitely mood disorders. And so just for listeners, mood disorders is a kind of an umbrella term which incorporates depressive disorders and bipolar disorders. And in fact, folks that have a depressive episode will not, or typically will not, make attempts of suicide during a depressive episode. And it can be up to 3 months after where they may make an attempt for suicide. And so it is, again, very challenging. But the 54% piece is interesting, because I think that they may not have a mental health diagnosis. That doesn't mean that it was undiagnosed, or did they go to treatment, or, et cetera. So, it does get a little fuzzy there.
This is a big area of controversy in the field, I should say. I think that some people believe that almost everyone who died by suicide had some kind of diagnosable mental illness, whether it was diagnosed or not, whereas other people don't think that. They think that that's sometimes the case, but that there are ways that people can become suicidal even if they wouldn't have a diagnosable mental health condition, through stressors like struggling with housing or legal problems or relationship issues. And so I think it really speaks to how hard it is to study suicide very precisely and to get a good picture of what's going on. And so I think that that's part of why the field, at least in some areas, has prioritized what do we know, what can we identify, and what can we learn from that, given that the data is necessarily going to be a bit limited in term and challenging to gather in this area.
Well, going back to the risk factors I was saying before, is the reason the data is important is because it's helpful for folks like you and I and other clinicians and even family members or friends to kind of spot and notice things. So I guess we can talk about, you mentioned this, there's an appendix in the workbook, but about what to notice. And so most people, it happens, but most people are not going to say, I want to kill myself. And that's how you know that they're suicidal. Most people are going to do an assortment of other behaviors or things that will kind of be, in a sense, signals. Whether they're intentionally doing that or not is probably unlikely, but that can kind of alert people to these things. So any types of withdrawing themselves, spending more time alone, giving away other things, precious items they have, making contact with people that they haven't for a while and kind of like, smoothing things over, making sure things are fine between them. Those are some of the ones that come to my mind. What are some of the kind of warning signs we can see with suicide that can alert us to maybe put our antenna up a little bit?
Absolutely. And I can also, there's a great paper by Chu et al. From 2015, which I can send you the link to if you want to put it in the show notes. They highlight some of the acute symptoms of suicidality, some of which you mentioned. One is kind of an agitation or irritability. Sometimes people will describe it as though they want to crawl out of their skin. They just feel so agitated. Sudden weight loss that's unintentional. Sleep disturbances are a big one. I think sometimes they can be missed, but if someone's suddenly having worse insomnia, nightmares, and things like that. And then you mentioned withdrawal, which is another big one. If you just notice someone's disconnecting from people. So those are some of the big acute risk factors to look for. Like you said, you can't always know, but if you notice those things, it's certainly important to check in with the person and see how they're doing and see if they're struggling and if there's any way that you can help them.
Yeah. And I think the thing that's, so I'll make one disclaimer about this. Mm-hmm. What I'm not saying and what you're not saying is that if someone starts giving away their stuff out of the garage that they're suicidal, right, or if they're a little irritable that they're suicidal. That's not what either of us are saying. It's more of a kind of sort of a composite where you start to see a bunch of these symptoms together. Then you can say, okay, and if you're seeing it over consistently over time, every time you're talking to them on the phone or every time you see them at, so-and-so's house, and it's always kind of the same kind of, temperature, if you will, there's these kinds of things, that's where you might want to definitely check in. I think the hard thing about this is that most people don't know what to look for, and most people don't address that or talk about that stuff, and it's hard for people to do. And not to say that this is your cousin or your acquaintance or your coworker's job to do this, but I think it can be very difficult to kind of notice or spot things in certain people sometimes, which is an interesting thing to, as something as serious as suicide, and no one ever wants to have see someone that they know or love to attempt or complete suicide. It is still hard to kind of put people in a place where they're like, well, what could I say or what could I do? And then you say, well, notice these things. People get real shy to like ask about it or to talk about it. So it's a very, we can know what the things are and we can know, what to look for. But then the kind of, for many people, going the next step of like, just striking up a conversation about it is terribly awkward for people. So, what are your, I guess, ideas or thoughts about that?
That's a great question, because I think that people are afraid they're going to somehow make it worse if they bring up the topic. But for people who are struggling with suicidal thoughts, a lot of them experience a report, both in people that I've treated in therapy and outside of that they feel really validated or good if someone's like, are you struggling? Like they can notice it, because maybe the person's struggling and they're hoping someone's going to notice, but they're waiting to be asked. And so the way that I usually just pretty direct about it, I notice these things and I'm wondering if you're struggling. So I noticed that you don't seem like yourself. You're not hanging out with us as much as we used to hang out. Or I noticed that you're not really responding when I contact you. What's going on? I'm worried about you. Are you struggling? Is there anything I can do to support you? And so just those kind of direct things. If you know some history about them or have reason to believe that they're suicidal, it's fine. Have you been having suicidal thoughts? Or sometimes if for example, someone's gone through, they're struggling with a difficult medical diagnosis, or they've recently lost someone, or, you can say, sometimes people who go through these things think about killing themselves, and I'm worried. Are you thinking about that? And we don't know, if not everyone is going to answer honestly for whatever reasons they are, but some will. And it's worth, therefore, kind of putting yourself out there and trying to connect and pushing through, as awkward as it may feel, to try to reach out to those people.
Mm-hmm. Yeah. I totally agree with what you're saying. I'm sometimes a little more direct than that. And again, you're absolutely right. People will say, I mean, I have, when I, teach graduate students, they'll, when we go over risk assessment, they don't want to ask, do you feel like, have you have any suicidal thoughts or suicidal attempts or ways of planning? They get very nervous about asking that so directly. And I've had to tell them, you especially have to ask this for a variety of reasons. So, I mean, I don't know about you. I've encountered this in my personal life. So, clinically, I've this is, kind of second nature, right? Doing this kind of risk assessment, but it happens in my personal life too, on a very few occasions. And, that's a different wrinkle, right? It's one thing to when you're at work or you're kind of have that hat on, you're kind of there, but when you're, not doing that, and it's, somebody, family member or friend or whomever, it's a little different. But I think the same piece applies is just like, okay, someone, calls you or texts you or sends you an email or whatever. And they say, hey, not feeling so good, or I'm not feeling down. I mean, that to me right there is huge, right? Because most people aren't going to do that, right? Or they're going to wait for you to kind of pick up cues. So if someone comes to you and tells you that, I mean, that's like kind of, right there. And then it's, obviously you want to explore it and see where people are at, but then it's, at some point in the conversation, I usually will say like, okay, well, how low are we feeling? What are we talking? What kind of low are we feeling? Pretty low. And then I'll just come out with it. Okay. You thought about trying to hurt yourself? Thought about killing yourself? Yes, no, whatever, whether the answer is okay, you go from there. But, I just come right out after. That's not the first question I'll ask you. I'll, get some context, what's going on, what's happened, if there's like a big, what we call a psychosocial stressor, someone died, someone lost a job, someone left them, whatever, it doesn't have to be those things, but sometimes those things can trigger some of this stuff. And so, yeah, trying to make sure that, people know, what's going on, and that if they're reaching out, they're reaching out to you for a reason. Typically, sometimes it isn't a reason, but I don't know how it is for you, but for me, people definitely will reach out to me because of what I do for a living. And so it's like, okay, that's good. I'd rather them reach out than not, but, and it's just, all of the risk, assessment and aside, if someone feels, let's just take kind of I don't want to say in a classic case, but if somebody feels, let's just say it's, kind of from the depressive kind of, mood or whatever more recently, or, really struggling with those, hopelessness feelings, the empathic or compassionate stance here is that if you're trying to put yourself in that person's shoes, which is really hard to do with someone like that, trying to imagine how low you have to feel that you don't want to be on the planet anymore is a dark place to pull someone out from. That is, they've given up, or they feel like it. And I don't know. And again, this is probably work for more clinicians than kind of lay folk, but I don't know entirely if it's about, I don't know what you think about this. I find there's a balance of, well, you don't want to be overly positive. It's going to be fine. It's going to be okay. We'll get through this. I think there's an element of that for sure. You want to instill hope. You want to, but I do think there has to be a serious recognition of how, dark their symptoms are. The human condition is tough, and that's a really shitty place to be in. And it sucks. And absolutely, it's not, there's nothing abnormal about you because you're feeling these, it's just, and it's not to normalize it too much, but it's to not further contribute to that shaming kind of piece that's already kind of, there. And so it has to be, I think, that balance of both. What are your thoughts on that?
I 100% agree. First of all, with being direct, I think that's right. I think that certainly in clinical work, asking directly, and the research shows that if you ask people if they're suicidal and they're not, it doesn't plant an idea in their head. So if you ask them and they do feel suicidal, that can be helpful, but it's not going to harm them by asking them. The research, there's been some great research on that. But then secondly, I agree with you that part of the discomfort that people have in talking to someone who is in their lives, who is experiencing suicidal thoughts and suicidal desire, is that it is excruciating to think about someone you care about being in that place where they see little hope and where they're in pain. And there are a lot of people in valid pain. It's not something that you can just say, okay, we'll just look on the bright side. That's dismissive. It tends to shut down conversations. So if you really want to help someone, you're right. The first thing you have to do is really get their perspective and where they're coming from, because otherwise any suggestions you might have are going to kind of ring hollow, because it's not going to be relevant to their life, or it's dismissing or showing that you're uncomfortable, and it might shut them down. And so I think kind of understanding that pain in the first place is important, as hard as that is, if you really want to support someone.
Yeah, I 100% agree. And it's a strange thing. I think, or I don't want to say strange, but it can seem counterintuitive, I think, to people, right? Asking directly, you know, sort of validating where they're at, that it's a real experience they're having. Those things are kind of counterintuitive. And then it's, you know, obviously supplement with everything else. I want to ask about how you conceptualize passive versus active suicidal ideations, and why that's important, because that's something that clinicians will, you know, debate about. You know, you could, if you're doing rounds or whatever, and someone brings up a case, you know, half the room, if there's 10 clinicians in the room, half of them will say, yes, you know, do not pass go, don't collect 200, straight to the hospital. And other clinicians will say, oh, you know, continue to do the risk assessment, you know, go over safety plan, you know, check in on them, but there's no need for that. And so sometimes many times there is a gray area for this stuff. And how do you understand that? So maybe, I mean, you or I can, it doesn't matter, but maybe let's just define passive active suicidal ideation, and then how do you understand it, and then how to kind of go about navigating that.
Sure. So passive ideation tends to refer to when people are having suicidal thoughts, and they can include things like they wouldn't mind if something happened to them, if they got hit by a car, or their car went off the road, or they never woke up in the morning. They wouldn't mind being dead, but they're not thinking about a plan or an intention to do it. Whereas active thoughts tend to have more of an idea of what the methods might be, about when they might do it. And so that's the distinction that I think that there are a lot of people who stay in kind of passive thoughts, but there is a risk for that turning into active thoughts. And I think as research trying to predict when that happens for people, it's very hard to predict, actually. And so, but it is useful in knowing in that moment, if they're at imminent risk for hurting themselves, if someone has a plan, say in the next week, of how they're going to hurt themselves, or if they have a method plan, then that's considered more active and less passive. And that's, for many people, more concerning, that they're at higher risk for hurting themselves, because they're kind of closer to that, the steps that it takes for someone to die by suicide.
Yeah, no, I agree. That's usually how I split it too. A lot of the things that I hear a lot is, well, I just don't see the point in living. You know, there's no point in living on the earth, or, you know, everything around me sucks. There's nothing really, you know, to live for. Right. I wouldn't mind if I didn't wake up. That's usually the passive stuff that I hear. And that's not something to necessarily, you know, get out on speed dial the hospital or, you know, the crisis team, but it is something that you want to explore. So then when it becomes more active, you know, my follow-up is always very specific. Where are you going to do it? When? What hour? What method? How are you getting the method? How are you going to set it up? Like, I just go real specific. And usually at that point, I've had a few cases, but most people don't get that far typically, unless it's a very acute, you know, suicidal kind of piece. And that's just because of the setting that I'm working in. I did mobile crisis for a couple of years. And so that was like, boom, right there in the moment, like, super acute. But, currently outpatient, private practice stuff is, you see less of that as a comparatively. So, but I do think when it's active, it is important to ask all that stuff. And some people do. Most people, when they're more on the active side, it's, well, I was looking up online most effective ways to kill myself. What did you find? Well, X, Y, and Z. And where do you feel about it now? I don't know. It's always the gray areas, the gray answers. And that's what's so tough, is it becomes there's always a fork in the road in terms of clinical decision making, right? And you always want to err on the side of caution than not, especially if it is, but I think on the passive side, and this is why I think your book is really helpful, is if somebody is, okay, I don't know if I want to wake up tomorrow, or I don't know if I wouldn't mind not being alive. Okay, then maybe for clinicians, they're not going to be placed in a hospital. But if that person's thinking that way every single day for weeks and weeks and weeks, that's not smart either. So you use a continuous checking in on things. And so I think that's where, treatment can be really helpful, of trying to correct some of the negative thoughts and trying to understand or have a broader perspective of what's going on. And so there's a passive, any suicidal ideation is not good, but passive is, while it's not as, urgent in the sense of like right now, go to the hospital, it can kind of over time become, very, very challenging for the person as well.
Yeah, absolutely. And sometimes it can happen quickly if something major happens in their life or something changes. And also, like you're suggesting, it's not kind of this dichotomy of, are they at imminent risk now? If not, then let's move on. It's very, very painful for people to have these thoughts. It usually comes from a deep well of suffering. And so it's important to address those thoughts. And I think that's a way also in therapy for patients to feel like they're cared about, that it's not just you're thinking about, okay, what do I need to do in terms of hospital or not, or is it emergency situation or not, or how deep do I want to dive into this, but to show you're taking it seriously at whatever level that they're having these painful thoughts. And so I talk about this in the book, and certainly other people in the field have talked about this too, about making a crisis plan for people wherever they're at, so that they have in place, should those thoughts become active or more severe, they have a crisis plan in place for things that can help soothe the emotional pain that they're having, have people they can connect to, that they can have safety from methods. Do they have guns in their home? Are they safely stored? All of that kind of stuff, I think, is important for anyone at any level of suicidality. It's nice to have a crisis plan in place, because in the moment of the crisis, it's hard to do those things, especially on your own.
Yeah, I think, so on that, so I haven't thought about this in a while. So let's make the distinction here. And this is a little bit more in the clinical world, but so when I worked in mobile crisis, we used to do this thing, it's called a safety contract, right? Which, over time, as we thought about this and looked at it and did it, it's really bullshit, right? It doesn't really mean anything. Basically a safety contract, for listeners was, you meet with somebody, you de-escalate. Okay, they're not actively suicidal. If they were an hour or two ago, you have them sign a piece of paper that, the clinician and the person says, like, at this time, I'm not suicidal. I have no plans or intentions. They sign it, they date it, whatever. The efficacy of that isn't really, I don't know. I think it's weak. The person can just turn around the next night and, if they have the thoughts again after the person, team leaves or whatever, and then it's not really effective. And that's different from a safety plan. So what are your kind of thoughts on that?
Yeah, I'm glad you brought that up, because the idea of having a safety plan or a crisis plan isn't someone promising they're not going to hurt themselves, because in a way that's kind of asking them to just say they're not going to do something. Instead, it's trying to give them things they can do when they're in crisis. And so the crisis plan really focuses on what are your warning signs? When will you know that things are getting worse? For some people, it is that the suicidal thoughts are worsening, that they're withdrawing from people, that their sleep is bad. And so the workbook guides them finding some of their personal ways that they know, and then talks about ways that they can cope and gain support. And it gives them specific things they can do versus saying, okay, I promise not to hurt myself because of the reasons you're saying. There's not really a lot of evidence, if any, for the efficacy of a no harm contract. The idea too, and I've seen this in therapy work well, is that sometimes going through making a crisis plan with people and then they share it with a partner or a friend or someone else in their family, that can be helpful too, because it's a way for them to communicate about their mental health needs, and it opens the door for someone checking in on them more regularly and just knowing what they're going through. So sometimes they don't know how to start the conversation, but they can say, like, here is what I talked about with my therapist, and here are the things that are helpful to me. And so that can be useful too.
Yeah, I'm glad we see this the same. I never really liked safety contracts. I never really thought they didn't really mean anything. But a safety plan is a little bit different. So typically, I mean, it is going to be a little case dependent, but just in a general sense, what do you typically kind of organize in a safety plan for clients? And again, I know it'll be individualized based on the certain antecedents and the client and what's going on and stuff, but just in a general sense, what are like the things you usually put in there?
Sure. So one of the major things that we talk about one is having emergency numbers that they can contact, whether those are hotlines or warm lines where they can talk to peers. That can be helpful, but also some people, like, their go-to people, and they might be people that they talk to because of mental health struggles, but they can also just people who, like, lift them up or who make them laugh, or some, there can be different reasons for that. Try to list reasons that they want to live, because that can be hard when you're in a crisis to remember those reasons that you want to live. And so that's usually part of it. And then also ways to make the environment safer. And so that's part of the crisis plan too, whether that has to do with moving razor blades or having someone else help hold your medications for a while or whatever it might be. And then ways to distract yourself, because sometimes in those intense suicidal states, brief periods of distraction or time to get through that pain can be helpful. And the idea is to get through that moment and make it through that moment with some tools and some support.
Yeah, I like that all tracks as well. I like how you kind of organize it though, because I think one of the first things that I've seen and that I've used is usually, contact, right? And it's usually, okay, well, here's the national hotline, right? Here's the, crisis team in your area, if there is one, depending on where you're at. Most major metropolitan cities have one. New York does, DC does, Baltimore does, Philly does. I mean, I think most do. I don't know about in other places more rural. It's probably less so, but maybe. And then typically the nearest, hospital or clinic or whatever, so they know. And those things are usually good to just have in one place. The last thing you want to do when you're feeling pretty low is to be looking for a stupid phone number, right? So, right. So that's important to have. And then, typically, at least in my case, definitely people that are close to them. So parents or spouse or a good friend or somebody like that. I usually tell people that I'm like fourth or fifth in line to get contacted, and then after that, it might be the psychiatrist that they see, who's prescribing medication. You can always see them as a emergency appointment if that's the case. But I always tell clients, but please let me know. Don't not tell me, right? I don't want to know the next session, like, oh, by the way, usually it's, just send an email or whatever and just say, hey, just had a tough night last night. Can we chat today? Of course, something like that. So there's usually a type of plan, right? Certain types of people around, the environment, removing certain objects or, things that could be harmful. And then, kind of the things that they can do kind of internally or intrinsically to kind of calm themselves down, which I think is where I want to get to levels of care. But one of the things we can talk about is there are some things in your workbook that I think are helpful. If someone is in that kind of spot or that space, what are some of the things in the workbook that you would kind of point to in that moment? So you're not going to start at page 1 and just work your way through. At that point, what are some of the things that you would do? Would it be there's plenty of exercises in the Increase Hope chapter, which is really nice. Or that's the one that jumped out to me for something like that and a little more acute. What would you say? Where would you point to, I guess?
Yeah, I think the hope exercises can be a good one a good place to start. I know people can overdo acronyms in therapy, right? And so I didn't want to overdo it, but on the other hand, I think that they can actually be helpful for remembering things. And so
Sure.
The idea of the hope framework is seek help. And then in the workbook, it goes through obstacles to that. And a lot of time when people are feeling suicidal, they feel like they're burdening other people or there's no one to turn to. And so the exercise in that tries to help people to think about pushing through some of those obstacles and thinking about things through different perspectives. The finding optimism is not about a false sense of hope. Like we talked about, the idea is about finding legitimate things that people can look forward to. And this comes a lot from talking to people who've had suicidal crises where they'll say, something like they wanted to have a cup of coffee the next morning from the place they like. And that was just something small to look forward to, or there was a family gathering to go to, or they wanted to read the next book in whatever series they're reading. And so I do think those little things can help. The P is about changing perspective. And there are exercises in the book specifically for challenging things people who are struggling with suicidality often are very hard on themselves and they don't think there's any way anything can change because they're in that place of pain. Yeah. And so those exercises kind of guide them through looking like, well, are there other circumstances that you've been able to get through? Are there other positives about yourself that you're not seeing? And then the E is about attending to emotions, because sometimes I think when we experience painful emotions, understandably, we want to push them away, but they're telling us something. Maybe we're tired, or maybe we're lonely, or whatever it is. And so that section really focuses on identifying what is this emotion telling me, and how can I meet that need and nurture it instead of putting myself down for having the feeling at all. The HOPE acronym, the art in there by Elise Roriani, she used sparklers, which I really like, because it's kind of the idea of hope can be a spark. It's not this thing where you are in a deep, dark place and it's all of a sudden everything's fine if you do these exercises. It's about finding those little sparks and kind of building from there to get through those moments.
Yeah, no, it's great. That was one of the things I liked. I mean, some of the stuff in the beginning, it's just kind of your standard, CBT. Yeah. There's a thought record in there. Some of that stuff, and I didn't see any wheels though. I see wheels in CBT. I didn't see any of those, but that's
true.
There's a thought record. There's a few other things that are familiar, but it's just kind of couched in some of the, kind of the language specifically for folks that are, having challenges with suicidality. So all this stuff can kind of be helpful in an acute moment, but I guess it may be helpful here to just maybe go over just briefly kind of the levels of care, because this is something that I will talk about with clients, and it really pains me that they just like, no one ever told me that. I'm like, oh my goodness. And I think it's important to know and just say it publicly, and it's probably a good place to do it. So you can help me along and see if I stumble on this. So typically in mental health, so if anybody has a mental health challenge, whether that's undiagnosed and you feel that way, or if it's you are diagnosed and it's chronic, if it's more acute, etc. Any types of mental health, there are certain requirements, and this is going to depend obviously per institution and per state, etc. But the highest level of care that one could receive for a mental health crisis or challenge is a psychiatric inpatient hospital. It's the highest level of care that we have. You're 24/7, round the clock, eyes on you, nurses, psychiatrists, psychologists, therapists, etc., social workers. And the point of, in this moment, now I have my own opinions about inpatient hospitals that are probably unpopular, but the point at the moment is that to be inpatient is almost always, unless you're in a forensic inpatient placement, and that's really just, that's just all risk assessment. You just make sure that they're not harming other people or themselves. But for the most part, inpatient is usually seen as a way of trying to stabilize and to be safe. And so usually within 72 hours, they're trying to see, when are we going to discharge you? And I tell folks this when clients, people have these kind of antiquated ideas, which is some of the problem with media, that it's one flew over the cuckoo's nest. And that's just not how it is at all anymore. And so now there are certainly places where people will stay a week, 2 weeks, 3 weeks inpatient, but typically we have tried to really do away with kind of the long-term inpatient hospitalization, again, unless there is usually a forensic component. And this is like the old NGRIs, the not guilty by reason of insanity and so on. So that's the highest level of care. And the point of that is to be safe, right? If you're actively suicidal or you made an attempt, you need somewhere to be safe. You need somewhere where you can be no access. You're in a place, you're trying to, go at baseline to see where you're at, see what meds work, get some kind of intensive treatment, and then see about discharge. There are 2 phases right after that. So the next one after that would be partial hospitalization programs, which is basically you do all of the things you would do in an inpatient unit, kind of more long-term, but you only go for a certain amount of hours per day. And so this is usually heavy on, look, we need to, it's a lot of group work. So a lot of group therapy. You'll usually see a therapist, maybe some check-ins and 1 or 2 sessions a week. You'll usually see a daily or multiple times a week of the psychiatrist to see how the meds are. And you're doing the program. There are other things too. Sometimes they have dance therapy, art therapy. There's different types of therapy that can be done in a place like that. Or it could be more specific. So, if there's a co-occurring element of substance abuse or things like that, but it's something where it's usually like 8 to 3, 8 to 4, and you go home and at night and you come back the next day. And that's usually, anywhere from 3 to 6 weeks, typically. Again, depends on the placement. Right after that is the usually intensive outpatient program, so IOP. And that's usually where it looks similar to private practice. The only difference is that it's more intensive. So you might see, your therapist twice a week. You're working on something very specific. And you have usually groups, sometimes not always. You will have nurses or PAs or psychiatrists as well. But you're not staying there the whole day. You're going there for an hour, 2, 3 hours, and you come back, and people are able to work and still do everything that they need to do, but they just need a little bit more care and investment. And then there's just your standard outpatient placement and or private practice, which is your kind of, probably stuff most people see in films or TV shows now, which is you go to the therapist 50-minute hour once a week, and maybe see a psychiatrist once every 3 months, and you're usually stable enough. And so the whole point of all of these levels of care in our mental health system, it's not a perfect system by any means, but each thing has its placement based on what the client's clinical presentation is, in terms of, okay, if symptoms start to exacerbate or something happens, well, private practice can't see you 3 times a week, right? That's not, it's as soon as you're asking for that, you need a higher level of care. If you feel actively suicidal, will you jump all the way up to inpatient, to stabilize and to be safe? And so I think in terms of folks that have certain mental health challenges or they have, any type of suicidality, for clinicians, it's important to kind of have in their mind, okay, where does this person fit in terms of the level of care? Because the worst thing that a clinician can do is, think they can do it all and be a savior. It's like, no, don't do that. Whatever the presentation is leads, and that's where it has to determine. And so when we're talking back to that kind of passive suicidality, that active suicidality, you want to obviously look at the symptoms, but then in terms of, well, where is the right level of care and placement for folks that based on where their symptoms are at? So that was a long way of me explaining the levels of care. Sorry about that. Do you have anything you want to say about that or add to it or correct me on?
No, I think that's a good description. I think often what happens in practice, maybe in your practice too, is that I'll ask people, do you want to do a higher level of care? Do you feel like that's necessary? And sometimes they do feel that way and sometimes they don't. And so it can help to understand where the person's coming from. It can be another way of getting to understand their perspective and what their needs are. And sometimes it's just helpful for people to know that if things get worse or things change, that there are other options out there for more intensive therapy as needed.
Yeah, for sure. I guess the other, just the kind of, this is more of a talking shop kind of thing, but I'm just curious, do you usually have any types of assessments you give clients, self-report measure, screener, any type of risk assessment that you typically use to try and kind of get some quantitative data along with clinical judgment and qualitative stuff typically?
Sure. I work in a medical setting, and so they've kind of have a protocol that they set. So they use the patient health questionnaire, which has a question about suicidal thoughts. Yep. And if the person says that they have been having them, then it automatically goes into the Columbia Suicide Severity Rating Scale and asks more specific questions from there. And then that kind of opens up for a clinical interview, and from planning from there. The Tu et al. Article that I've mentioned a few times has a nice set of interview questions and prompts too that can help to know how to ask questions and kind of have certain phrases. But I'd say the PHQ and then the Columbia, and then usually the dialogue goes from there. And those have been helpful for keeping track of more of some of the quantitative type things and just opening up the discussion and understanding where people are at.
Yeah. So I guess the other piece of this that is maybe surprising for some people is connected but not always implicated is what we call self-injurious behaviors. Do you want to just kind of, I can tee you up for it, but maybe just tell us how you define that, what that looks like, and how it is not necessarily a suicidal gesture, although it can be. Maybe talk about some of the nuances there too.
Sure. So self-injurious behaviors or self-harm, non-suicidal self-injury, as usual in academia, there are multiple terms for the same thing.
Yes.
But self-injurious behaviors are typically when someone is damaging their tissue or hurting themselves in some way without the intent to die. The most common ways that people do that are by cutting or burning themselves. And there are different reasons people do that. The most common one is to reduce pain or reduce negative emotions. Other times people will say they're doing it to communicate to others, and people, especially who maybe experience trauma, will say it's to feel something, even if it's pain, to combat numbness. And so people who engage in those behaviors are at higher risk for suicide attempts. And there are different thoughts as to why that might be. It might be because the underlying mental health distress that's going on is driving both suicide attempts and the behaviors. Another part of it goes back to that aspect I mentioned before, that's part of Joyner's interpersonal theory of suicide, which is capability. for suicide. And the idea is that when people hurt themselves repeatedly, they may have less fear of pain or of enacting lethal self-injury if they desire suicide.
So we see this unfortunately happen with young people a lot. Is there, and and it usually, my experience, and I don't know the data on this, but is that you don't see it too often with people that are older. I mean, you can, but is there any reasons as to that, in terms of why it typically tends to be, I mean, very young now, which is very troubling. People in young in middle school, and obviously high school and college, and then you don't really hear too much about it with folks that are in their late 30s or late 40s typically. Is any ideas about that?
Yeah, it's a good question. I think one of the thoughts behind it is that people, as they get older, are hopefully developing other strategies for coping with emotions as they go along, whereas younger people might have less tools available to understand how to cope with their emotions. But there's also been some suggestion that there might be a social aspect of it, that people talk about cutting and learn about it and maybe try it because they have heard of other people in their circles trying that. And I think that happened to some extent when I was in high school, but with the internet being what it is now, which is much bigger than it was then, I think that people can kind of find groups, and on one hand, other people who may be self-injure or cut. And on one hand, I think that can be really helpful in terms of connecting with other people, understand them, but also it might have some negative effects in terms of seeing, oh, other people are hurting themselves this way, and maybe I'll try that. So I can those are the things that my speculation would be just fewer tools for coping, and also maybe learning about it socially.
Yeah, I definitely think that's, with social media, the internet the way it is now, it is more, I don't want to say normalized, but in a sense, yes, with younger people. And I think that's obviously problematic. I want to ask about that, but before we get to that, so how do we know that, for the layperson, well, why isn't this a suicidal gesture? Like, why is this, like, it's dangerous? I mean, right? If you're doing these types of behaviors, what is the ways in trying to say of like, well, how can we make the difference between that this is someone's trying to kill themselves, or the difference of just saying, no, I'm trying to feel pain or relieve pain, or how can we make the distinction?
I honestly I think the best way is to ask people. And I think that what they meant to do, and what they were trying to do by that. I think that that's the clearest way to understand. And then you can also look at kind of what they were doing. Where were they injuring themselves? For example, some people who are cutting themselves without the intent to die might be cutting themselves in areas that are on their thighs or by their arms, or something else that is not as connected to a suicide attempt as other places on their body. And so I think that those are the main ways, is trying to explore it with the person, and also looking at the context, as you were mentioning before, kind of what are the other factors that are involved? What else are we seeing here? Are we also seeing some of the desire for death? Are we also seeing, because some people who are self-injuring they'll say, I have no interest in dying. I don't want to do that at all. In fact, part of why I do that is to feel better. And so that, I think that kind of exploring that with them and then looking at the bigger picture can be helpful.
Now, some people may ask about this, and so this is a little bit removed from suicide specifically, but some people may ask, like, well, my goodness, like, why would someone cut themselves to feel better? That makes no sense. How would you explain the rationale with that? Because when you first hear it, it's like, wait, what? That doesn't make sense. You're putting some type of object to harm your body, and that's going to cause physical pain, why would you do that? And why would that make you feel better? How do you usually respond to that?
Yeah, you're right. It does feel very counterintuitive. I think of a couple things. One is, and I've written a little bit about this, is there's some hypothesis about kind of endorphins being enacted when people hurt themselves, kind of when you exercise really intensely or really hard or something like that. And so there can be some relief feelings that our body uses to cope with pain. And so that can be a secondary physical effect that happens. Another part of it is that if your emotional pain or numbness is so excruciating that cutting yourself or burning yourself feels better, then you can really try to imagine the place that the person is in. Yeah. We're wired to pay attention to injury, right? That's an evolutionary survival instinct. And so if we're in pain, our attention is going to shift maybe from the emotional aspects, whatever's going on in our minds, to I'm bleeding or I've been burned or whatever it is. So it can actually draw the attention to things that are less painful than the thoughts in the person's mind.
Mm-hmm. Yeah. Which again, I think says everything you need to know about, my goodness, the amount of pain this person must be in if they're going to do something like that to distract or to have some sense of, neurotransmitters of the rush or the danger. Even if that's a very big sign about things. And I think the problem becomes with that is that it works, right? People feel that. And so when you're trying to have, what do we call this? Non-compensatory strategies, right? When you're trying to have other strategies that are healthier to deal with the pain, that can be difficult because it's like, I don't, what are some of the alternatives? I don't want to hold this stone and think 10 happy, positive thoughts. I'd rather just cut because it's, it works and it's right there. And, this is not as effective within that framework, and, how do you kind of mention that? You mentioned it a little bit in the workbook, but not, I don't think, expansively. Again, it's a little bit outside of suicide specifically, but what do you, in terms of kind of techniques or certain things, better coping strategies, what are your thoughts on that?
I had a supervisor who did dialectical behavior therapy, focused a lot on self-injurious behaviors. And I liked her advice and her framing, which is to just be direct and honest with the therapy patient and say, holding a frozen orange or ice cube may not as intensely relieve your emotions, but what are some of the benefits of using that instead of hurting yourself? Do you feel a greater sense of mastery? Do you feel you're not worried about infection? And so I think taking like a very real approach with that and saying like, hey, we can look for some alternatives and they may not feel as good. You may not get as much relief, but at the same time, you might not have as much distress surrounding it too. So what are the pros and cons and why might we want to commit and try to this? And so then it's kind of looking at what are some intense things that are attention grabbing that don't cause tissue damage. And so I mentioned holding an ice cube is something from dialectical behavior therapy, intense exercises, if appropriate, a very hot or cold shower. Those types of things can sometimes help come out of that state a bit and lessen the pain.
No, yeah, absolutely. And one small bit here is that much of self-injurious behavior can tend to be, or was historically seen with borderline personality disorder, folks that have that personality disorder, I think eating disorders as well. Am I correct on this? And a few others, but those are kind of the ones that usually jump out at people, right? And so the kind of, I don't say danger or risk, but where clinicians have to be very mindful is to not assume, cutting or self-injurious behavior must be one of these two disorders, but those are those behaviors are more specific, and they do happen probably, I would say, more with certain disorders than others. Anything you can say about that piece of it?
Yeah, I've done some research looking at, and what's been proposed for the DSM is having non-suicidal self-injury disorder as a separate disorder, because it does tend to be transdiagnostic.
Yeah.
And so I think what I would want to do, and kind of the theme of what we've been talking about, is a larger context and the larger constellation. So are there other symptoms of borderline personality disorder? If so, that's good to know, because that can help with treatment. Or is it more related to PTSD or post-traumatic stress disorder? And if so, is that one of the triggers that is pulling this? And so it's very much about looking at what's underlying it, what tends to trigger. And people might not know if they've been doing it for a while. So sometimes the first step is just having them notice and kind of record. In fact, the research that I'm doing now is on a grant that's looking at non-suicidal self-injury and eating disorder behaviors. And it's using ecological momentary assessment, where they're in their natural environments and they get a signal and are asked, like, have you injured since the last prompt, which could be hours ago, because it's hard to track these things. They become habits. Yeah. And so I think that kind of looking at is it interpersonal stressors? Is it conflict? What's pulling on that can help get a clearer, like, diagnostic picture of what's driving the behaviors and how to best address them in treatment.
Yeah, I think that's really important, because, typically the kind of caricature of this was, well, folks that were really serious about this, they would try to do it in places you can't see, or cover it up, wear long sleeves, wear pants all the time, et cetera. Where it became more attention-seeking behavior that you would sometimes see with folks with personality disorders. And that's just messy, because they could do it, and they could sometimes want it to have attention, and other times not. And so it's just very difficult to tease that out. But then you walk around with a tank top and, seeing all of the scars, that's like, okay, and that aside, some of the diagnostic stuff aside, if you see someone that has, or any of those types of signs, or do see markings, if you know the person, or if they come to you, or if they're hurting, it's, I think, a good thing to have compassion, especially for clinicians as well, to not, think that someone's just trying to be attention seeking or what have you. I think we never want to assume those things.
And you're right. Historically, with personality disorders, there's been a lot of stigma and dismissing, because even I think if someone needs attention and that's the tool that they have to use, then you're right. Being compassionate, that's valid. Yeah. I think that it is important to pay attention to it and to be open-minded, and rather err on the side that someone's really suffering and we want to help them, rather than make other assumptions and miss something.
Absolutely. I totally agree. So one thing I wanted to ask about was, this is a loaded question.
Okay.
Which is saying something, considering the topic we've been talking about. So the role of social media, or mass media, I guess you could say. So this would be television shows, films, social media, or cases that become more public in the news. It seems, you tell me what you think about this. So the big thing that I think comes to mind is the Netflix show 13 Reasons Why. Mm-hmm. And a lot of mental health clinicians, psychiatrists, psychologists, therapists, and I would be in that bunch, we're not too happy about this show. It does have a type of glorifying of use of sorts of suicidal gestures, and that is very dangerous, I think. I don't work too much with adolescents. I do occasionally, but I have also with people with with young people that are, again, as we talked about, young people are doing some of these behaviors more than not, but things like Snapchat or TikTok or some of these other apps where it becomes a type of social signaling of sorts. And there becomes, in one way, so there's two things here at play. I would say the glorification of things and kind of linked to that is all in the spirit of destigmatizing mental illness. You hear this a lot, right? Mm-hmm. And on the face of it, it sounds very respectable and admirable. And yes, we don't want to shame people or make them feel guilty or abnormal or crazy or all these kind of, antiquated terms. But I think what's happening is the other extreme where when adolescence is a shitty time anyways, right? It's like you got all these things going on. You got, not just hormones, but you got interpersonal relationships, stuff with family, identity. It's a messy time. And then on top of that, academics and career and what you're doing. And emotions are going everywhere. And it seems that there's, with young people, this through these apps, that's why I mentioned them, this kind of oversharing of sorts of things, right? That they're sharing all their feelings, all their thoughts. And so now, okay, it's fine to share about mental illness. So I'm going to share that, I thought about killing myself last night. And then the other one's like, yeah, me too. And it becomes this kind of, there's a sort of social capital that's there. And then there's this, I've heard certain adolescents where they'll have these certain types of, I don't want to say rituals, but these things that they'll do with, finding creative ways of cutting and hiding it and then telling each other about it and then showing as like a kind of symbol of sorts. I mean, there's all these strange things that happen all under the guise and the spirit of, we're just being out about our mental illness. And this is part of who I am. And that's what media is saying, right? That's plenty of shows and plenty of things that are talking about that. And we need to destigmatize mental illness, but it still becomes a talking about something instead of actually dealing with it. And, and then, making it very difficult, I think, for clinicians or people that are trying to work with individuals because, they're posting on Facebook, basically a Dear Diary entry, and everyone in the world literally can read it and not have that, that's not their data anymore, and making some very serious claims. And when social media, you're going to get two things that happen. Number one, you're going to have half of the responses, whether this is on any form of social media, Instagram, Twitter, Facebook, Snapchat, half the people are going to do this. Oh my goodness, I feel so sorry. Thank you so much for sharing. And it becomes a reward, right? Well, if I just keep doing this and I keep sharing this and I keep saying this, I'm going to keep getting the sympathy. I'm going to keep getting attention. I'm going to keep getting that this is okay, right? And again, it's behind the, destigmatize mental illness, right? I need to, own that part of me, which is true. I'm not saying that that's not true. The second half is you're going to get a bunch of people that are going to potentially be, when you're sharing anything about your mental illness, especially if you're sharing suicidal ideations, vague or not, A, that's not the right forum to do that, and B, it's like going into a battlefield with no armor on. I mean, you're just so exposed to the vitriol, the vile, the absolutely horrible things that people can say online, and that can make someone feel worse. And so I just don't see anything helpful of sharing your very intimate, personal mental health challenges on social media because of those two opposite extremes. What are your thoughts about all of this kind of, this is a real issue. This is stuff that really is, you get clients that are young people, adolescents, young adults, people in college, this is a real thing. And there are times where it can end very tragically because of a handful of comments that were said. And they're just going to be like, yeah, that is true. And then it just it's really dangerous. And so, I know I sound like the boomer right now and just like, oh, those kids with their social media. Like, I'm really not that. I mean, I'm not saying that, but I think with this specific thing, it is very exposing, and it's not the forum to do that. And you can destigmatize mental illness in more appropriate, healthy, psychologically adaptive ways. So do you can disagree about, obviously, but what are your thoughts on any of what I'm saying?
Well, I mean, I think that, so I'm going to say it's complicated, but I'm going to say more. I'm not going to leave it at that, I promise.
Go ahead.
So I think personally, I tend to lean more towards privacy. And by that, I just mean online. I think people should be open with people they trust. I mean, that's a huge chapter in the book, is about connecting with people and being open. I worry about internet stuff. And you're right, that does make me sound like I'm just like out of touch. And maybe I am, but it's there forever. Anyone can access it. And it's harder to sort through who means well and who doesn't mean well. And so to me, I very much think, especially with young people, that it's important to look individually at what they're doing, how it's affecting them, and help them draw some boundaries around it, or depending on their age, working with their parents or caregivers or whoever to draw some boundaries around it. Because what we want to do is maximize the positives of people feeling connection and feeling open. And some people feel like their only social support is from there. Sure. And we want to maximize on that while reducing the harms that can take place. And I think that working collaboratively with people can be one way to individualize that, because it is, for some people it's going to be neutral, but for some people it's going to be maybe start as beneficial, and other times it only takes a few people to make it turn into something harmful or that really brings people's moods down.
Mm-hmm. I totally agree with you on that. I mean, I think that, social media by design, I think, is great. I mean, it's to connect people, and it's to connect people all around the world, and you can find, certain groups that can be helpful, and you can, but maybe I'm more against it than you are, I guess. I don't know. I feel, it makes me feel really uncomfortable for people, and especially young people. I mean, I'm on Twitter and I see adults acting like children half the time. And it's just like, oh my goodness, these are adults, who knows what they're dealing with, and people would just say just the most vile things to somebody.
Yeah.
Hiding behind the black mirror on their phone or their screen. I'm like, you don't know what this person's dealing with. You don't know what it just on both ends, really. But it gives people this kind of weird liquid courage that's on steroids. It's just it's too much. And so when you put young people in the mix that are so impressionable, and if they are, and young people do have, high rates at the moment of depression, anxiety, I just think that's a bad combination. And, so I'm not anti, teenagers or young people being on social media. I know I sound super old right now, but it has to be heavily curated, I think, heavily filtered, because it can be very risky.
Yeah, I think that's true. I mean, I think that the research is not always really clear, but that's because it's hard to study with individual impacts, and but I think from a practical, sensible level, and I agree, I feel protective, especially of young people, of what they're sharing with, what vulnerabilities they have. And I think I tend to err more on the side of caution on those things and be more reserved. If they're adults, they're going to do their own thing, and you can talk as a therapist about pros and cons of certain things. But for youth, they're more vulnerable. And I agree. it's hard too, because I think there is pressure to be online a lot for young people. And so it's unpleasant battle, I'm sure, for a lot of parents because they're like, and it was other things before it was social media, but
Sure, yeah.
my friends are able to do this and their parents don't care if they do this. And yet it's important because younger people, they can't really totally foresee what some adults who are looking out for their best interests can see. And so I agree with you on that. I think that it's important to be really cautious about it.
Yeah.
And yet, I guess the other hesitation, not to waffle, is I think there are some people who, like, I'm in North Dakota, and there are some people in rural communities, for example, that belong to groups, maybe they're transgender or they're gay or whatever it might be, that they're in a small town and their only way of connecting with people and feeling okay is through social media. But even then, I hear what you're saying. You're not talking about not connecting. You're talking about like what exactly is being shared and put out there for the world, which makes a lot of sense.
Yeah, no, absolutely. And I was thinking about that when I was saying what I was saying was like, I'm well aware that, folks that live in more rural areas, this is great. They can connect with other people that are, they share some things with their identity or with their interest or whatever. Absolutely. I mean, I live in Western Maryland, so I mean, I don't, I'm not in North Dakota. I mean, I've been in North Dakota. It's a rural place. It's lovely. It's beautiful. Yeah, it is. I think that could be helpful to connect, but you're absolutely right. The distinction there is, what are you sharing when you're connecting through that space? And I think that's, I think, again, you're talking to young people that are, a little more impulsive, a little more emotional typically. And, it's harder.
I know I was, right. I don't think I had the best judgment about who to trust and what to share with people.
Absolutely. Yeah. So, but I think it's a particular challenge. Every generation has their challenge. So I don't think it's, it's so like, different. I think it's just a different medium, literally, but I think it's just being mindful of it because of the reach and how fast things go. And I think that's where I get really a little worried.
Yeah, the reach and the permanence where people, that's scary too. I don't mind that. I mean, social media was around when I was younger, but not the way it is now, where it's like, it's fine with me that some of the things in my life were private and will stay that way,
Yeah. Well, that's in some ways, I think it's a little bit harder now for this generation because they're literally born into it. And so their whole life is going to be somewhere online. And that's going to be, very interesting in 30 years, or sooner, what does that look like, So, but yeah, there's parts of, for you and I, most of my childhood is not anywhere on a cloud somewhere or right. It's just not. So, yeah. So I want to just talk about the workbook. So I want to be kind of clear about my reading of it. So I thought it was great, and we've touched on some of the stuff in it. I obviously want people to get it and to buy it, but I think you say somewhere in there, I'm almost sure that this is not, no workbook is, but this is not a replacement for therapy. And in fact, it's a adjunctive to therapy, if you will, or maybe some clinicians that are listening, or grad students, they can use some of the stuff in here, but it can also be, just the person that's a non-clinician can pick it up and use it and go through it. But, to be clear that's the intention, we talked about it kind of at the top, was, you can go through it start to finish, or you can kind of jump around, but it's not a replacement for therapy or anything like that. So what is the ideal way or the best way that you want people to use it? How would you want clinicians to use it? And just talk a little bit more about the best use of it in particular audiences and et cetera.
Sure. So one of the things that within people who are struggling with suicidal thoughts talk about is finding a therapist who has the training and expertise to help them. And I think sometimes that's really hard to find. And then on top of that, sometimes due to geographical reasons, financial reasons, therapy may not be accessible, or therapy that is specifically targeted towards suicidal thoughts is not accessible. So that was a big reason that I created the workbook for people who either they don't want to go in and talk to someone. There are a lot of people like that, and they want to start with self-help and privately work through things. That's one reason the workbook is there. And then the other reason, like I said, is having difficulty accessing it. In terms of how therapists can use it, my hope is to give them more tools and ideas for understanding suicidal thoughts and behaviors, and to empower them to feel like, okay, this is something I can help people with, because it can actually be really, it can be really hard if someone is turned away from a therapist because they're having suicidal thoughts and the person is like, I'm not really comfortable with that, or it's outside my area of expertise, because suicidal thoughts are pretty common across a bunch of different areas of mental health. I think it's actually important that clinicians understand whatever their main focus area is, how some basics of safety planning and how to help people who are struggling. And so what I was thinking, and this is kind of the way I work as a therapist, as I have some of these workbooks and manuals and websites that I like. And if I'm talking to a patient about something and something specific comes up, and I want to share with them a resource that they can look at between sessions, or that can kind of expand on it, or we can work on together, I'll photocopy that, or I'll send them a link to it. And so I can also view it like, for example, if someone's struggling with acceptance of a situation and it's causing them a lot of distress because they are having trouble accepting it, I could see taking the acceptance exercises from this and sharing that specifically with a patient, and then talking through it that way. And so it gives them something to work on. And I have found with some patients, like, they really want to talk about it. That's their main thing. But for other people, they want to kind of write and work on something and then bring it to therapy. And so I could see it being used that way too.
Yeah, that's how it feels. I think some of them are a little bit more step-by-step of sorts. And then others are more kind of like a way of, like, many people have trouble organizing kind of their abstract thoughts and feelings. And so it kind of does that. It kind of gives a skeleton, if you will. And again, you can deviate from it, I would assume, if you want, but there's a sort of type of outline that they can kind of get their thoughts or their feelings out, and then, work in tandem with a therapist. So that was my read of it as well. I mean, I've, seen plenty of workbooks in my career over the years. And so this one was great. I mean, it really was, because it really has this kind of flexibility with it. And I think it's really good that it's predominantly centered on alleviating suicidal thoughts and feelings and all the rest, and trying to say, okay, how can we deal with this? And so again, like I said at the top, not a big workbook person, but this was something I would definitely recommend. And I think it's there's a lot of really good things in there. And so I think it is wonderful.
Thank you. I really appreciate that. You work on something by yourself for a long period of time, and so you don't know how people are, if it's going to kind of be as effective or useful or seem like a good resource to people. So I really appreciate the feedback from a colleague like that. So thank you.
Absolutely. I think as I get older, I've become more and more flexible with things, and try and say, like, everyone's going to have a different space that they're in, and they're going to need a different kind of thing. And I work with clients now where sometimes they want something tangible, so it helps me too. So before I let you go, just a few things. You've done work, you mentioned it earlier, but you do work with folks that have eating disorders. This is correct?
Yes, I don't do clinical work currently with people with eating disorders. I have in the past, but the research is, okay. I actually, the grant that I just started in April is a project that is part of a center that's studying eating disorders.
Yeah, I have an excuse to get you to come back on here for later, but I guess the one big thing is that the common knowledge with eating disorders is that it's a heavily, it's a 9-to-1 ratio female to male. It's just 90% seen in females, at least in the reported cases. Is that changing at all? Again, hard to know, right? But are men reporting it more? Are we seeing it a higher number? Are we seeing it more with men, or is it just still predominantly? And I'm sure you can make many inferences from society and culture and things like that about body image and et cetera, but is it still heavily female, or is there any change on that kind of 90-10 split?
One area that you see closer to something like gender parity, if you want to put it that way, is with binge eating disorder. You do tend to see much larger proportion of men that are struggling with it. And then the other area, I think that it's kind of sometimes gets grouped in with eating disorders, sometimes gets grouped in more with body dysmorphic disorder, as it is currently, is muscle dysmorphia, and kind of viewing oneself as not muscular enough. And the reason it sometimes gets grouped in with disorder eating, because it can involve extreme diets or protein monitoring and supplements and things to the point, and body image issues to the point where it's really disruptive and distressing. So I think that paying more attention to those presentations helps us to understand and be more aware of men who are suffering, but there have been more outspoken men who have talked about their struggles with eating disorders. And I think that has helped more people to recognize if they are struggling with it, or recognize their friends who are men or boys who they maybe previously wouldn't have recognized as having an eating disorder.
I mean, I am not well versed. I know it exists. I'm not well versed on literature on this, but I mean, there is an insane amount of correlation of, shame and eating disorders, self-conscious emotion of shame. And so it's hard to talk about. I mean, people are so ashamed of this stuff. I mean, it's really, really tough. And also because food is just, a thing we need to survive. It's something we do every day. And so it's just it's really, really tough. Just kind of on a more lighthearted bit of this. There's a new show on Apple Plus called Physical with Rose Byrne. And it's, again, I don't work with folks clinically. I haven't done research on it. I know stuff from grad school and a few, workshops and stuff, but so I'm not an expert by any means, but it has a really, interesting, and from what I can tell, very good portrayal of the kind of internal dialogue that folks that have eating disorders go through. I mean, there's a kind of like dark humor to it, but it's very good. And there's even I think it's before or after the show, a kind of boilerplate kind of language about, if anyone has eating disorders, you can call this number, et cetera. So and again, I think more so now than in past years, there are select few shows and films that really take care to try and show, I mean, it's obviously, it's Hollywood and stuff, but to try and raise some awareness. Here's a picture of what it looks like. There have been a few select shows that I've liked and be like, yeah, that's kind of spot on. And so it's a newer show. It's been out a couple weeks, but a couple episodes, I was like, wow, the kind of inner monologue was what I've heard descriptions of folks that have eating disorders. So
wow, I'll have to check that out. Yeah. It's called Physical, you said?
Yeah, it's set in the 80s, and it's semi lighthearted, but it's like a drama / comedy, but it's interesting. It's very interesting. She becomes a, what are those things in the 80s? Those jazzercise classes.
Jazzercise.
Yeah. She becomes one of those, but it's, there's this, I think there's no spoilers, but the first episode is her, like, that's going to happen. And so kind of how she gets to that point. And it's just this kind of on a loop, her going to like a fast food place. I don't know if it's McDonald's or something. And her inner monologue, okay, this is the last time. This is the last time you're going to do this. You're not going to do it again. And then all the like hating kind of language, you're fat, look at your this, look at your that, and it's the inner model. She's doing the voiceover while you're kind of just seeing her expression in it. And it's interesting. It's really interesting.
Yeah, that sounds right on. Oh my goodness.
Yeah. So real quick, just we talked about, really heavy topic, and one of the things that can start to happen with folks is when somebody does one thing, they're just kind of known as that person that does that one thing. I'm friends with Jonah Paquette, and he was on my podcast in the early stages. And he's seen as like the awe guy, right? Awe and wonder and all of that. And he, wrote a really nice book on it. And he's like, I do like other things. I do other things in the clinical world. And so you do as well. So aside from research and clinical work, you have a podcast as well. Is it still current? You're still doing that? Yeah.
Yes, I had one podcast called Jedi Council, and that ran for about 3 years. And now I have a podcast called Psychodrama with my friend and co-host Leonardo Bobadilla.
Oh, nice. And you guys talk about psychodrama as a type of there's a type of therapy that people use for that, or is it just more of looking at themes in certain film and shows, or what's the premise?
Yeah, it's disappointed a few people who are interested in the type of therapy psychodrama. It's actually about societal controversies, psychological science, and clinical practice. So the drama is more referring to controversial type issues, but it is very much focused on, we've had a lot of guests on different areas of psychological science, and especially areas that people have divided in different views on. And so we try to have them on and kind of aim for some type of discussion and in a way that I think is hard, like we were talking about in social media, it's hard in a tweet to get it, but in a podcast, you can have these broader discussions. And so that's what we do, and we enjoy it. Because it's just kind of, there are some serious topics, but then we started off talking about like stand-up comedy, which we both like. So it kind of is an opportunity to explore our other interests too.
Yeah, that's great. The last thing I'll say here is, I am a huge, people who listen to this podcast, they know this. I try not to talk about it too much because then I get distracted, but I'm a huge Star Wars nerd. I have liked Star Wars since I can remember. And I read all the books. I watch all the shows. I do the expanded universe. I'm one of those Star Wars freaks. I don't dress up. That's the only, I have not got there yet. I will not do that. I will not dress up. I thought about it when Force Awakens came out, but I did not do it. I promise. No shame in people that do. I just, that's not me. But so I'm not at that level, but I play the video games. I mean, yeah, I build the Lego sets. I mean, people in my house, my family makes fun of me for how much I love Star Wars. I mean, they do too, just not the same. So it's like one of those things when, many people were watching The Mandalorian and, we got a lot of, traction. People liked it and stuff. And every episode, I would give them like the full download of how everything is connected in the expanded universe. So I'm one of those Star Wars nerds. Where's your Star Wars nerddom, and what is your current thoughts on the current state of Star Wars?
I love Star Wars. I am not as in-depth knowledgeable as you are. I do have, can't see it, because this is an audio podcast, but even though we're on video, I have a very large Princess Leia Rebel poster on the other side of the room that I'm in. And so I love Star Wars, and that first podcast was called Jedi Council, which was kind of started off looking at psychological aspects of Anakin Skywalker and other characters. And a lot of that was because that's when I was a professor and teaching at the time, and the newer Star Wars were coming out. And so that would be one way that we would talk about different mental health issues, is talk about characters, Kylo Ren. And I mean, there's a lot of interesting psych stuff, and they're just fun movies. I actually am one of those people who is okay with the prequels, and the new ones, I just like the whole Star Wars universe very much.
the question I usually ask people is, and you're going to get different answers when you ask people, if someone has, and this still surprises me, if someone has never seen Star Wars, they've never seen a Star Wars film, which is crazy. It's been around since 77. It transcends like 3 generations. If you haven't gone to grandparents' house, your parents' house, or if you weren't raised, it's still surprises me that people have not seen it. You got kids now with the new films. I just don't understand how people haven't seen it. But if no one has seen a Star Wars film, what's the order, and what's the order to watch them?
That's a good question. The first one I actually saw was Phantom Menace, which everyone hates, but I liked enough to look at all the other ones. I don't know. I've heard, what is that one? It's like what is that one called where you skip one? I can't remember what it's called, some series, but I like the idea of all of them in order. I know that's not the most dramatic way to do it, but that way works for me. What do you think?
Well, I've seen them way too many times, and I have watched all of the films with people that haven't seen them, and I will sit down with them together and I will watch them with them. And it's always fun to like see the reactions on certain big moments and stuff. Cause for me, it's I'm never going to have that same reaction. So I always say to do it chronologically, or excuse me, in order of release, excuse me. So 4, 5, 6, 1, 2, 3, and then 7, 8, 9. And then I don't put Rogue One or Solo as mandatory viewing because it becomes a little confusing for people.
Yeah.
Right? And so now if you are watching them 1 to 9, I sometimes will say, if you're doing it in that order, sure, you could do that. And it kind of fills a lot of, holes. I mean, Solo is a really good movie.
Yeah.
It isn't really necessary, but it's a really good movie. I think Rogue One is top 3.
I loved Rogue One. I was really impressed by it because I'm like, we know how it's going to end. How good can it be? But I really enjoyed it.
So good. My personal favorite. So I love the prequels. Many reasons why. People that hate on them are, they make all these things about like, oh, the acting's terrible. And, it's over CGI and it's all these things. And it's like, did you watch the originals?
Right.
Nostalgia that's in the way. The acting was terrible then. The writing was okay. And it was just the other end of CGI. It was terrible. Right. It was, is a couple scenes away from just being like a B movie almost. I mean, it was just, it's great. I mean, they're national treasures in my mind. I mean, the original, to me, it's the story. The story is what's amazing, the characters and the story. And so I can get around some of the other things. And I think Revenge of the Sith episode 3 is one of the best films. Yeah. It's amazing. But my order is the flashback order. So you watch 4 and 5. So New Hope and Empire Strikes Back. And so you get the big reveal, and then you go back and you watch episodes 1, 2, and 3 as if it's a flashback of like, oh, how did this person and this person, how did that happen? And so you go back and you see Darth Vader. And then after you watch 1, 2, and 3, you go to 6 and then you kind of see it. So it kind of operates as a type of flashback. And then you do 7, 8, 9. And then you can watch the other 2 to kind of fill in the gaps. That's my favorite way. I think last year I watched, my daughter and I, we watched them, I think in order. So we watched all 11 films in order. And that was a lot of fun. We hadn't, because they were all on Disney Plus and stuff. So we just like sat down and just, watched one a night or something for a week. And it was a lot of fun, week and a half. I'm not crazy about the sequel trilogy. I'm not crazy about it. I really like Force Awakens. I thought it was really good, even though it was kind of copy paste of A New Hope story-wise.
Yeah, it was. It really was. It
was really awesome, though. I liked the characters. It felt like Star Wars and like really good Star Wars, like good mix of the CGI and the animatronics and stuff. And, it was good actors and good writing, and it was great. I did not like Last Jedi, and Rise of Skywalker was a mess. So I really have soured on the sequel trilogy. I don't hate them, but it was just disappointing. And so I do like I love The Mandalorian. I think it's great. I loved Clone Wars, Rebels. I'm enjoying The Bad Batch at the moment. Those are the animated ones. They're really good because it's all canon. So it all fills in. It's not just, some people riffing off of it. So it's official and stuff. And so in my mind, Dave Filoni is the only one that can save Star Wars. So I'm a big fan. He gets everything about Star Wars. That dude's like a walking encyclopedia of Star Wars. And he gets the essence of it too, and not just all the facts and stuff. So I hope, they put him all the way to the top and he just runs it at a certain point. I think he's pretty much almost there. So he's great. I totally trust him. I think he does great work, and it'll be really interesting. I've been reading the books for the High Republic that just came out, that era. So there's different eras of Star Wars, and that's been a lot of fun. So it's always fun those are the types of ratios I like getting on Twitter, where I'll have some kind of controversial thing about Star Wars and people get all angry at me. I think I put, this is last year, I was just having some fun. I think I put a picture of, from episode 1 of Anakin Skywalker. And I said, tell me why The Phantom Menace is the best Star Wars film, because it totally is. And oh man, people, I put all the hat, and people were so angry. And I'm not really being serious. I like Phantom Menace. I mean, but the best one is Empire. But I like Phantom Menace, and it was fun having those types of what Twitter should be, right? Some fun, banter about, a movie or something, right? And so it didn't get too ugly, and that's the kind of content I'm there for. It's kind of fun.
Yeah, absolutely. No, some of those those pop culture disagreements can be from the funniest, most fun parts of Twitter, because it's not so personal. I mean, I know Star Wars is personal, but it's not personal. It's super personal for some Twitter people. Sometimes gets.
Yeah. No one attacked anybody's families or anything like that.
That's good. It's all that's good to hear.
Well, look, Katie, you were such a delight to talk to, even though we had to talk about a really hard subject. I really enjoyed talking about this in terms of trying to, I don't want to say educate, but really just inform people about something really serious, ways to look for it, how, for clinicians or students, even if they listen, what are some really solid ways grounded in research. And then your workbook is really good. It's very helpful, I think, for folks. And so thank you for writing that. Thank you for doing your research. And really thanks for giving me your time and your energy today to talk about it. I really did enjoy it. And I greatly appreciate it.
Thank you. The feeling is completely mutual. I really appreciate you having these kind of conversations and these discussions. And I enjoy talking to you too. So thank you so much for having me on.
Absolutely. And we will have to get you back on here again and talk more about the research you're doing. So
sounds great.
All righty. Thanks.